Miscellaneous meds. These are other things that you guys may see a lot, okay? And so there are ones I kind of want you to be aware of. Periactin, cyproheptadine. It's interesting. I put PTSD down here at the bottom. The first time I ever used periactin was when I was still doing my adult psychiatry before I switched over to child. And I was at the VA, and I noticed that all these veterans were on periactin, and I'm like, why are you doing that? And I had one of my attendings, who is Dr. Timmerman, who's wonderful, was like, it decreases the intensity and duration of their nightmares, the flashbacks that they're having. So I got very curious about it. So I started asking all these guys, yeah, you know, really, how is it working? What does it do when you take it, when you not take it, with your nightmares and the flashbacks? And then when I started my child residency, I worked with a lot of abused teenagers or younger kids, you know, boys and girls who were being physically or sexually abused. And so I'd get these ones who'd have these flashbacks and these nightmares. And I started using a little bit more periactin, cyproheptadine. And then all of a sudden when I started learning more about the ADHD, that people use it to stimulate their appetite for kids who are having ADHD problems, it's one of those another ones where it's like, wow, this is a very interesting medicine. It's pretty safe and does lots of different things. So you got to ask why somebody is using it. You can use it for migraines. Can help with that. Appetite stimulation. If somebody is on a stimulant and they're not eating at all, you give them this and it can stimulate their appetite center. Sleep, it can be a little sedating, so you can give it at bedtime and it can help with sleep and appetite at the same time. PTSD, if they're having nightmares, I'll use it for that. So you see, it's one of those things that you may see a lot with kids. Who knows why they're using it? Okay, lots of various reasons. The other one, DDAVP, it's for bedwetting. So if y'all see that, more often than not, the pediatrician is going to prescribe that, not so much the psychiatrist, but sometimes we will, depending on what it is, especially if you have a kid who's on lithium and doing great, but lithium can make you pee. So if you put them on this, they may not wet the bed, so you see how you're kind of countering something. But once again, you're using a med to treat a side effect, which is not, it's not always good. Try not to do that. Last right here, you got migraine and seizure medicines. So sometimes you'll see those, like I mentioned earlier about seizure meds. Just because somebody's on Depakote, though, don't say, yeah, you must have bipolar. Maybe it's somebody who's just got absent seizures. Okay, so you always want to kind of ask, you know, why are you on it? Couple resources that we have here. This is one I kind of like, the Parents Med Guide. My favorite, though, is these two bottom ones. ACAP is the American Academy of Child and Adolescent Psychiatry. That's our national organization that all child psychiatrists belong to. These practice parameters, what those are, they'll be one that'll have, like, let's say, an ADHD practice parameter. And what they are, those are guidelines that they send to all the child psychiatrists saying this is how we should treat things. Okay? There's a practice parameter for treating, let's say, oppositional defiant disorder, conduct disorder, for treating depression, and it kind of tells you, almost like an algorithm sometimes, do this, think about this, do this, and so they're really, really good practice parameters. The other thing is that one of my all-time favorite things from there is there's this thing called Facts for Families. And what this is there's about, I think, 80 or 90 different things on there. It may be your child and television, or how to talk to your kids about violence, or ADHD medications, ADHD, bedwetting, you know, all these different things. And what you can do is you can go up to their website and it pulls all of these things up and you can click on one. And so if you're sitting in an office and you're like, wow, I've got this family who's coming in who, you know, the kid's getting bullied. What is some simple resource I can give the parents? Well, you can pull this up and you can click on the bullying one and it'll print it up and it'll tell them about resources, what they can do to help prevent the bullying, how you can help talk to the kid about it, and it's great, great, great resources. Before we had computers in every office, I'd actually had printed all these up and I'd keep them in my office. And when the families would come in, because there's a list of just kind of, the list tells you all the different ones and where they are, I would just go Xerox it and hand it to the families, you know, when I was in training years ago. So now that it's online, you can just print it up right then and stuff like that for the families. And it's a really kind of neat resource. So with that, any questions? I think it's been kind of a lot of stuff. I'm trying to think if there's anything that I kind of really missed. I may have, I don't know. So what questions y'all have? Yes, ma'am.
Could you talk for just a minute about, I had this 3.5-year-old little boy that was on Hygiene and melatonin. He was very violent and aggressive in daycare. And so the doctor started him on Risperdal. And isn't that, do we mix Risperdal and Hygiene?
You can very carefully. So the question was about can you well, there's lots of layers there that we'll talk about. 3.5-year-old who was on clonidine and melatonin and then was aggressive, so they put risperidol on. So when you look at that, first of all, 3.5. You already heard my spiel on that. Don't use meds if you don't need to. Okay. Melatonin, if the kid's having sleep trouble, you can use melatonin, and it'll help with that. So with the clonidine, was the clonidine being used to help with sleep? And if it was, why were there two different things? Probably the clonidine was to help the aggression, but it was probably still given at bedtime, right? Or even twice a day, either bedtime or PM. And so what happened is they're thinking the right way. If you've made the accurate diagnosis and you say this kid needs some treatment and he needs something, clonidine is an okay one. 3.5, you want to be cautious because it can cause blood pressure problems in kids at 3.5. Still, their body hasn't figured things out yet. So you could use it if you're careful. But then if you have to switch to another medicine like risperidol, that means probably that the clonidine wasn't doing its job completely. So my preference would be to say, yes, you can use the risperidol. It's safe to use in kids that age if you have to, but you don't want a 3-year-old on 3 meds too. So maybe you should think about getting rid of the clonidine or something else. Risperidol and clonidine together can cause a lot of blood pressure problems, a lot of other stuff. So I don't like that combination together.
But you said not to take them off the clonidine without tapering off, would you?
You know how my tapers are? If they're on 0.1 of clonidine, which is usually what a lot of people are on, I'll say go to a half tablet for 4 or 5 days, then stop. That simple. I mean, it's easy, you know. But because what happens is like we mentioned earlier about the caffeine, everybody drinks caffeine in here. Okay, if I said tomorrow none of y'all are going to get caffeine, all right, you're going to have some sort of withdrawal type something, some kind of crankiness or irritability. But if I said tomorrow or for the next 4 days, all of y'all can have half the amount of caffeine, and then on day 5, no more caffeine, it's going to be a lot smoother for you. Okay, that's exactly what it is. That's why I always recommend almost every medicine. Very few that I say don't taper, but most of them I say just taper. And most of my tapers I do are anywhere from 4 to 7, 8 days. You can get off them quick, but you want to fool the body into thinking that, oh, they're still there, it's still there, and then it's gone. So, what else? Yes.
I actually have kind of the same question. I have a 6-year-old that got placed in my home, and he's on the risperidol and clonidine as well, along with the Adderall. I mean, I've been watching him really closely, and he's been doing really well, but should I have a concern that he's on both of those?
No, and that's why when she said, should he be on both of those, when I'm kind of like, well, because I have some kids that are on both of those. But if you're just throwing those on, that's not good. But if you have a kid who's stable and doing well on the current meds, I'd kind of leave it for now. Now, what's happening in a couple of weeks? It's summertime. So if there's ever going to be a time where you're thinking about, do we need to do something different or change things, that's the time to do it. But if a kid's stable, why change something? I mean, if they're happy and they're doing well, as long as they're having close monitoring, then they'll be fine. So, but if you ever have the kid go outside and play and it's like, oh, I'm dizzy or I'm lightheaded, it's probably the combination. What else? What other stuff? And it doesn't have to be just about meds, say anything, I mean, child psychiatry stuff, whatever.
What is the deal with the Abilify that you see advertised on TV now?
So, I don't like meds being advertised on TV, personally. Okay. Wow, that's such a layered question for me. So the question, I don't know if y'all heard, was what about Abilify being advertised on TV? So if something's advertised on TV, the FDA has very strict rules about you can only say what it's indicated for. You have to talk about, have the disclaimers and have all that other stuff on there, and so they'll talk about the indications. My thing is that if a patient comes into me, I'm going to use my clinical judgment, and I'm going to use whatever I think is the most appropriate and safest med for that kid at that time. But with things being on TV, I'll get people to come in and say, I saw this thing on Abilify, and I really want you to start that. And there's a reason, because this just happened actually when my dad was in clinic. I guess 3 weeks ago, this person came in and was like, it was Abilify. You got to start this medicine. And he was like, it's really not indicated, but she talks back. Well, that's not a reason to start this. Went through we did the whole eval. I was like, not bipolar, whatever. Your husband just got divorced. I mean, there's all these social stressors. You moved to a new house. The girl's stressed. And the mother was angry and kind of like started to like yell, and I'm never going to come back here again because you're not going to start my kid on Abilify, and walks out of the thing. And you're kind of like, and that's, I think that's kind of what prompted it. Now, is Abilify a good medicine? Yeah, it's great. I mean, it works really well, just like a lot of the others work well. So kind of my thing is that they're doing it as a marketing thing, because there's a lot of places, like at the medical school up there at the Health Science Center, one of the things is that we actually can't get anything from drug reps, whether it's pens, whether it's papers, whether it's, you know, it used to be they'd take you to, like, you know, they could take you to dinner where they do these, where they'd have somebody speak about their medicine. UT, we can't do that, any of that anymore, because they say it influences you, it influences what you do. And so I think for more often than not, that's very true, is that it can influence you if you're not cautious about it. I think it was one of those pendulums that went way to the other side, that they're like, no contact, but it's also kind of one of those, if you're gonna buy a new car, you're gonna talk to the salesman and get some details. Some of the drug reps have some really good information, and I get patient resources. I get samples for my patients who can't afford it. I mean, I get lots of things, so it's kind of that thing. So when you do the advertising on TV, I think it's a way of trying to get people interested in a medication to get going. It's not focused on the physician, if that makes sense. Right. It's like an insurance company saying, you can't prescribe that medicine because we don't want to pay for it, when you're like, but that's with my clinical judgment, that's what I think the best medicine for this kid is. So that's why those are some of the battles we fight. So that's kind of one of my soapbox things. So I was trying to be careful about that, nice about how that. What else? Anything else? Yes, ma'am.
Yes, what would be considered a normal weight gain and an abnormal weight gain with your medication? What is the cause for concern?
You know, if you have a 30-pound kid who gains 5 pounds, that's pretty significant. If you have a 120-pound kid who gains 5 pounds, that ain't that big a deal. So it's kind of more about how old is the kid and how much is the difference. So usually what I say, 3 to 5 pounds, keep an eye on. If it's above that, that's when I start to worry. More importantly then, are they gaining the weight, is how are they eating? Okay, because some of the meds, when they stimulate your appetite, like any of the atypical antipsychotics, what it does is it makes you like ravenously hungry. And so they can't get enough, they keep eating. That worries me more than a kid gaining 3 to 5 pounds. Does that make sense? You always ask, they can't get enough food, they keep shoving things in, they're full, I know, but they keep eating. Okay, that's when you worry about it. So you also have to look at the size of the kid and how much it is. Because every day, if y'all weighed yourself every day, you could have 1 to 2 pounds different every day, just based on water weight, whatever. I mean, so you see, it kind of all depends on the size of the kid. But once you get above 100 pounds, 120 pounds, meds they kind of stable out. The meds do, and so the kids do too. So, kind of not a good answer. 5's usually the one that makes me kind of get above 5 is when I start to go, what's going on?
But do you also think that kind of is actually affecting or having the result you're looking for?
Oh yeah. You're right. So if they put on 5 pounds, or if they put on, let's say, 10 pounds, and the kid was already underweight, and they're saying, I am happy now, I mean, like, my life is good, and they have good self-esteem, then I'll tolerate 10 pounds based on the clinical outcome. So that's why that's a hard question. You think that'd be a simple question to ask, but that's actually a really pretty hard one, because it's kind of variable. Yes, sir?
Because there wasn't a slide on it, did you talk about some of the typical side effects or problems with sleep medication?
So, in a roundabout way, I'm going to answer that. So one of the groups of people that actually have come to one of my clinics, on my Monday clinics, are adolescent medicine fellows from BAMC. And they're people who've done 3 years of pediatrics and their second year of an adolescent medicine fellowship. They're awesome. They're so fun because they make you, having pediatricians in a child psych clinic makes you really think about things in a different way. And one of the guys who was there one time, he and I clicked just right off the very beginning, because he would come in, he'd be like, well, this kid's having trouble sleep, they want a medicine. And I was like, well, you gotta talk about sleep hygiene first. And he was like, I agree. And so he and I had almost the exact same spiel we would do on sleep hygiene. The problem with using a sleep medicine is you start to get used to it after a while. And whether it's a physical dependence, that you may get on something that you need it to fall asleep, like maybe either Ambien or something like that, or it could be almost like a psychological dependence that you have with it. using meds for sleep should be a little bit more of a last resort, temporary or a last resort. The first thing you want to do is I always tell families, we go through the process as we say, okay, what's bedtime? They say 9 o'clock. I said, then 8:30, TV, everything off, okay? Then you need to brush your teeth. You need to kind of either try to shower, calm down, get in bed, and even if they don't fall asleep at that time, read a book. Because if they're playing video games, you've got all these areas of your brain are lighting up, okay? You've got your motor area, your sensory area, you got your eyes, you got your, impulse control stuff, so you got, single adjust, all these things are lighting up, and your brain's not gonna shut down very easily. So I'm very much a big believer in saying, read a book, listen to music quietly, do something where you slow things down, and if you do all that and then a kid still has trouble with sleep, use the medicines carefully and appropriately. And so that's why when I talk about melatonin and trazodone, they're the least side effect things. I really don't like using things that have side effects. You look at the other ones, like I mentioned with the Ambien and even some of the Senescent and all that, you get to a point where people will say, I can't sleep if I don't have my sleep meds. And that's what I worry about more, is people becoming dependent on them, whether it's physiologically or psychologically. You run that big risk with all sleep meds. Is that kind of what you were? Okay, yeah, so I'm a big believer in sleep hygiene. Like I would write it down, do this, do this, do this, do this, and they're like, I don't want to take a shower at night. And I'm like, actually, it's not just that. I mean, you take a shower, it's kind of soothing and calming. The other thing is lavender actually stimulates this area of your brain that helps you sleep. So if y'all ever look at bed sprays and things like that, you notice they're always like lavender and stuff like that. So I get these teenage boys who'll be like, try it, trust me, try it. And they'll be like, I don't want to try it. And then their parents will get it and spray like Febreze or whatever on the thing. And these boys are like, yeah, I fell asleep. It was pretty great. Like, it's doing it, warm milk, all these little old wives' tales that we have. These things actually all have reasons why they work. So I would much rather say use those things first and then use a sleep med as a last resort. Except melatonin. Melatonin's one of those you can it's best if you use it for a couple days on end, but if I have people use sleep meds, I say use it for 3-4 days, then try to stop it for a little bit and see. So, yes?
And I noticed that you had something or medications for dyslexia. How would you know when you need it?
It's really interesting because I have it up there with that, but you actually can't treat dyslexia with a medication. Okay, that's because dyslexia, when you're like flipping the words and stuff around, but what happens, you also get kids who then they start having that secondary thing of they get frustrated because they can't do it, or they just start getting distracted because they can't do it, and dyslexia can go hand in hand with ADHD. So if you use like stimulants and things like that, some of the ADHD medicines, you're not actually treating the dyslexia, but you're giving the kids more resources to be able to focus on that. So they say, wait, I flipped that around, I'm staying focused, let me see how I can switch it back. Does that make sense? It's like oppositional defiant disorder. You see that. We don't have anything to treat oppositional defiant disorder, but there's studies that show that stimulants help with oppositional defiant disorder. And why? It's like what I mentioned earlier about the 8 seconds. Okay, a kid who's, you say the sky is blue and they're gonna be like, no, it's green, or it's light blue, just because they want to argue with you. The stimulants, what they do is they actually help them kind of pause. They'll be like, it is. They realize, I don't have to argue. It's not that instinct, kind of just, bleh, I'm going to kind of attack. So that's kind of how it helps with dyslexia.